Addressing the connection between mental health and chronic pain to improve patient outcomes. I'm Madeline, National Office. This webinar is being recorded along with a recording. I'm going to hand it over to Paul Gianfrido, Mental Health CEO, for some opening remarks. Thanks.
Thank you, Madeline. And for those of you, please use who are listening, please use the chat function if you're having difficulty hearing, as I am having a little bit of difficulty myself. But let me just start by thanking you all for attending this webinar and taking the time from your busy days to focus on something that gets too little attention. If I had to choose just one thing that's at the intersection of chronic disease and mental health, it's pain. And yet we often treat pain like we treat mental illness, telling people to just get over it. Most people can't, and so they turn to whatever they can to ease that pain, whether it's physical, emotional, or both. And that causes its own set of problems. Pain is present in so many conditions, and it is often chronic and debilitating. It affects the attitudes with which people experience life. It challenges their sense of hope, and it often leads people to depths of despair. 2 years ago, I lost 2 dear octogenarian friends to pain that was so severe. They chose to end their lives voluntarily together. Life with pain had simply become too much for them to bear. Today, we're going to talk about the connection between pain and mental health. We'll get some insights into that connection and explore some options for addressing it. We have 3 great panelists to take us on this journey, and I'd like to introduce them to you now. Maddy Reinert is Program Manager of Population Health for Mental Health America. Maddy manages the MHA Online Mental Health Screening Program at mhascreening.org, which has served more than 5 million individuals who have come to take a mental health screen and are seeking additional support. She has a master's in public health with a concentration in law, policy, and ethics, and has a particular interest in applying data-driven public health approaches to the prevention of mental health conditions. Monica Malampalli is Senior Advisor for Scientific and Strategic Initiatives for Healthy Women. Dr. Malampalli is a scientific thought leader and women's health advocate. As a trained biomedical scientist, she brings a unique perspective to health, from science and research to policy and advocacy. She's an expert in comprehending existing knowledge gaps and identifying critical next steps for addressing unmet needs in healthcare. At Healthy Women, she oversees health-related science and policy programs that align with Healthy Women's mission to educate and empower women to make informed health choices for themselves and their families. Gretchen Clark-Wortman is Vice President for Policy and Program for the National Minority Quality Forum, a health services research and education organization whose mission is to reduce patient risk by assuring optimal care for all. Ms. Wortman has more than 40 years of experience in the public and private sectors in health policy analysis, issue advocacy, health systems planning, and program administration. Ms. Wortman directs NMQF's engagement with federal and state policy and regulatory issues, coordinates the NMQF Neuroscientific Symptoms Working Group and their Alliance for Brain Health and Long-Term Care, and also leads their efforts in support of the NIH All for Us research program. It's an honor to have these panelists with us today. Now I'm going to turn things over to Jessica Kennedy for Mental Health America, who's going to moderate this webinar. Jess?
Hello, everyone. Thank you for joining us this Wednesday. This is Jessica Kennedy from Mental Health America. We have not advanced past the first slide yet for those who are waiting. We will begin shortly with our panelists. I just wanted to thank everyone for being here on this webinar with us. I will be handling the Q&A. At any time during the webinar, please type your questions in the chat room. I will quiet down. And I'm going to go ahead and turn this over to Maddy Reinert to begin.
Thank you, Paul and Jessica, for that introduction. And thank you to everyone for joining us today to talk about the important connections between chronic pain and mental health. I want to begin today by saying how honored I am to have the opportunity to present alongside Monica and Gretchen, who have done such extensive work in ensuring quality care for people with chronic health conditions. As Paul mentioned, I'm Maddy Reinert, the Program Manager of Population Health at Mental Health America, and today I'll be walking through the data that we've collected from people living with chronic pain and mental health conditions and exploring what that tells us about how to better support them both during and after COVID-19. Mental Health America is the nation's leading community-based advocacy organization dedicated to addressing the needs of people living with mental health conditions and promoting overall mental health. As a patient advocacy organization and an organization that was founded by Clifford Beers, a person with lived experience with bipolar disorder, we believe that our work should be person-centered and data-driven, and we strive to ensure that we're guided by what people who are seeking help with physical and mental health conditions are telling us. And one of the ways that we do that is through Mental Health America's online screening program. This program is a collection of 9 free, anonymous, confidential, and clinically validated screening tools that allow people to explore their mental health concerns online. Each of these screens are the same tools commonly used by healthcare providers to test for mental health conditions in a doctor's office. And we put them online because we know that when people first start experiencing mental health problems, they turn to the internet for answers, the same way we often do for our physical health. So when people turn to Google to find help for the mental health symptoms they're experiencing, they can take a screen and receive those immediate results, resources, and supports in an online space. And since its launch in 2014, over 5 million people have completed a screen, making this the largest data set ever collected from a help-seeking population for mental health conditions. Next slide, please. And this is important because the results help us understand people who are struggling. So it helps us to answer questions like, what are the particular mental health challenges that people are facing? Why are they coming to our site to take a screen for their mental health as opposed to looking for resources and supports in other venues? And how can we best provide them with resources and supports that are most relevant to them? So overall, what we want to know is, are we serving people well? And how can we figure out how to serve them better? Next slide, please. So part of how we answer those questions is by including optional demographic questions when someone takes a screen. And that helps us to get a better sense of who's taking a screen and what their experiences with treatment have been. So one of the questions that we ask is whether they have any co-occurring chronic physical health conditions. And when we looked at that data, we found that 31% of our screeners who report having another chronic health condition report that it is arthritis or other chronic pain, making it the most common reported health condition. You can see here that it's far higher than the next 2 commonly reported conditions, COPD or other lung conditions, and diabetes. And so we decided to look into the data from people who were saying that they had chronic pain and were taking a mental health screen. And this is what we learned from their responses. So demographically, we found that people who were coming to take a mental health screen and identifying as having chronic pain were much less diverse than our general population of screeners. They were overwhelmingly white. So 75% identified as white compared to our general population of screeners, where the breakdown is closer to census demographics, about 60% identifying as white. And this may be a result of people's experiences with the treatment of chronic pain. So research has shown racial disparities in reporting and diagnosis of chronic pain, particularly among Black patients, which may contribute to the lack of diversity in the screening population with chronic pain. We also found that 76% of screeners with chronic pain identified as female, which is consistent with the research that women are more likely than men to experience a number of pain-related conditions and to experience co-occurring mental health conditions such as depression. And then finally, we found that the older screeners were, the more likely they were to report that they experienced chronic pain. So about 60% of our screeners ages 65 and older who reported a chronic health condition said that they had pain. But chronic pain was also present among young screeners, with 17% of 11 to 17-year-olds and 26% of 18 to 24-year-olds also reporting having chronic pain. Next slide, please. We also found that people reporting chronic pain were more likely than the general population of screeners to score positive or with moderate to severe symptoms for a co-occurring mental health condition. So across all screens, 79% screened positive compared to about 74% in our general screening population. So definitely much more likely to be experiencing a mental health condition. Next slide. And PTSD, or post-traumatic stress disorder, is the primary concern for screeners with chronic pain. 48% of individuals who took the PTSD screen and reported having any health condition were reporting chronic pain. And they were more likely to screen positive for PTSD than screeners who took that same screen without chronic pain. And I want to pause here because the links between post-traumatic stress, trauma, and chronic pain are incredibly important, especially in the context of further traumatizing events like the COVID-19 pandemic and both the new trauma and re-traumatization that Black, Indigenous, and other people of color are experiencing now. There's a strong bidirectional link between trauma and pain. So people who experience trauma in childhood have a higher risk of chronic pain in their adult lives, and overall trauma exposure is significantly related to pain. But we also know that heightened stress and anxiety are associated with even greater pain intensity, and that greater pain intensity results in worsening psychosocial stress and factors that can contribute to worsening physical health as well, like greater social isolation, disruptions in sleep, and changes in health behaviors. So it creates this vicious cycle where trauma is associated with greater pain, and then greater pain can also be traumatizing. Next slide. And so what can we do to better treatment for people who are experiencing that cycle? So when we looked at the data about treatment experiences for people with chronic pain, we found that even among those who were screening with moderate to severe symptoms of a mental health condition, 1 in 3 had never received any kind of mental health treatment or support before, and 40% had never been diagnosed with a mental health condition. And that's among people who are screening positive. So although federal pain management best practices explicitly include the use of psychological supports in pain treatment, we're seeing that there's still a huge unmet need for mental health treatment and supports for people with chronic pain. Next slide. So now I want to describe what we've seen since the COVID-19 pandemic has continued to spread. So in April, as we began to see the growing mental health effects of the pandemic, we added a question to our demographics that asked about the top 3 things contributing to someone's mental health concerns as they were taking the screen. So what was bringing them on to screening? And we found that, unsurprisingly, based on our other data that I've just presented, that the top 2 concerns for people with chronic pain were past trauma, which was a top 3 concern among 61% of respondents, and loneliness or social isolation, which was a top 3 concern among 60%. And for people with chronic pain, we saw that these 2 things were contributing to their mental health concerns much more than the risk of COVID-19, which you can see near the bottom of that list, which was only reported as a top 3 concern for about 34% of people. Next slide, please. And then when we looked into the open-ended responses from that question, so from screeners with chronic pain about their top 3 concerns, we saw a number of things. So people are experiencing such severe pain and mental health problems during the pandemic that they're struggling to accomplish day-to-day tasks. We can see people saying that they're unable to take care of themselves or their household duties, or they're having extreme difficulty taking care of their day-to-day, week-to-week activities, including activities of daily living. We also see that they're worried about their families and their health, especially in a chronic disease context. And they're worried about being caregivers at this time when they may be experiencing troubles with their own physical and mental health while trying to care for their families. We also see that they're worried about not being able to use coping skills or pain mediation techniques like exercise that can help to alleviate that pain and stress. And finally, we're seeing that people are hurting all the time, to the point that it's hard for them to have hope, as Paul said at the beginning. And so we really need to figure out how we can better support this population. Next slide. So what do we need to do? First, we recommend expanding resources for team-based care with behavioral health as a central feature. So we know that from our screeners that people want care that acknowledges the interrelationship between mental health and chronic pain and effectively coordinates that care between conditions. And one of the ways that we can do that is to expand team-based care, but also include resources to support telemental health and telemedicine, especially given the shortage of mental health providers in many high-need areas throughout the U.S. and disparities in where those providers are located, and with the COVID-19 pandemic where people may not have access to in-person care. But as part of that, we also need to make sure that we're focusing on trauma and psychological supports. So we need to improve provider education around chronic pain and mental health and how to screen and manage pain. It's clear from our screening data that many people are not being screened for mental health conditions, even as they have been diagnosed with chronic pain or pain-related conditions. And some screeners have explicitly told us that they're looking for answers online because they don't know if their depression is tied to chronic pain or what to do about it. So knowing the high rate of comorbidity between the two conditions and that effective pain management often must include those psychological supports, it's important that providers feel knowledgeable and supported enough that they're not afraid to screen patients for mental health conditions and know what to do if someone screens positive. And that conversation really needs to begin with the provider. So another thing that we've seen from our screeners is a lot of people saying that they may not feel comfortable bringing up their mental health concerns, or that they already have several chronic conditions or several things that they're working with their provider on, and so they're not sure if they want to bring up mental health as well. And so we really need providers to feel comfortable and supported to begin that conversation and screen people without them initially asking for it in some cases. And then finally, we need better treatments for pain. So many of our screeners, even before COVID-19, when we asked what they needed help with, would say they just needed help living with chronic pain. And many also say that they've tried several non-pharmacological treatments like exercise or meditation that are now made even more difficult because of COVID-19, and they still haven't been able to find treatments that can work. So we need to make sure that we're investing in better but also more representative research to find pain treatments that work for a diverse population, so across gender, across age, and across race and ethnicity. And because we know that pain management works differently for different people, we also need to make sure that it is patient-centered and based on the wants and goals of the individual person. So even as we invest in that better research and better treatment, there's often a lag between when those interventions make it to individuals. And a lot of individuals are already saying that they're not being sufficiently supported by what's out there. So we need to ensure the use of patient-centered care and shared decision-making tools that can be updated with new evidence so that patients' values and preferences can be better taken into account when selecting treatment. So I know I'm already over time, so thank you all for your time today, and I hope that this information can guide all of us in creating better treatments and supports for people living with chronic pain and mental health conditions. So thank you.
Monica, you should be able to start presenting now.
Oh, great. Thank you. Good afternoon, everybody. I want to thank Mental Health America team for inviting healthy women to be represented on this webinar today. Next slide, please. For the folks who don't know us, we are a national nonprofit and have been around for 30 years. Our mission is to educate women ages 35 to 64 to make informed health choices. Based on our values here, we ensure that we are a trusted partner in providing evidence-based information, provide an independent voice in actually providing women's health information through our digital platform, and also provide thought leadership on critical women's health issues. Next slide, please. Before I discuss connection between chronic pain and mental health, I want to point out that both have a high prevalence in general population, as you can see from this recent stats here. It is also well established in research that mental health is a major comorbidity to chronic pain, and we've also heard Maddy mention some of that. Next slide, please. So I just want to share some facts about chronic pain. According to CDC, 50 million in the U.S. suffer from chronic pain. More women than men have chronic pain, and an estimated 1 to 3 women are impacted by chronic pain. Pain impacts middle-aged women and mostly women of color. And I've also mentioned the annual economic cost of chronic pain here, which was estimated by Institute of Medicine in 2011 to be $635 billion, and this estimate is towards the cost of healthcare and loss of productivity. Next slide, please. Chronic pain and mental health share a bidirectional relationship, just like Maddy had mentioned, and this evidence is based on epidemiological and clinical observation. Now, this bidirectional relationship is due in part to underlying shared neural mechanisms. So it's critical that we understand this precise relationship so that it can be useful for prediction of response to treatment for better pain management for the chronic pain patients. So on the right is an illustration to show the risk between chronic pain and mental health. So using migraine as an example, a patient with a migraine has 2 to 3 times more risk for developing anxiety, and a person with anxiety has twice the risk of developing migraines. And you can see this risk is much higher if someone has a chronic back pain, has 6 times the risk of developing depression. Next slide, please. So now we layer this with COVID and COVID's impact. So we know that since the COVID-19 epidemic, there has been a significant rise in anxiety, depression, PTSD among individuals with chronic pain. A recent U.S. Pain Foundation survey, which is shown here on the slide on the right side, found that 86 respondents noted that they have experienced increased stress, and 64% experienced increased pain as a result of COVID-19. So factors such as social distancing and knowing that chronic pain patients are immunocompromised and are at greater risk for COVID has made the problem worse. Next slide, please. So pain is complex in women. Not only are women at greater risk for pain than men, but women also have a higher risk for having multiple pain-related conditions and related comorbidities. So if you look on the chart on the right, women typically exhibit a minimum 2 to 3 or more chronic pain conditions, and that gender disparity increases when women have more than 4 conditions. Also, racial and ethnic disparities further impact people living with pain, but these disparities impact more women. So these disparities actually can make diagnosis and treatment complicated. We know that women tend to have high rates of current or past trauma, such as physical or emotional abuse, which predisposes them to PTSD. So when a woman has PTSD, she will experience higher levels of pain and emotional distress, as well as less function. Women are also susceptible to opioid use disorder, as it takes them less time to become dependent on opioids. They also take opioids at higher doses for longer periods. Furthermore, disability, stigma, workplace-related issues, access to care, and affordability of treatment are all important issues that impact pain management and the quality of life in women living with chronic pain. So, yet, whatever the reasons for these biases and these disparities, the tremendous effect on women's psychological health cannot be underestimated. Next slide, please. Chronic pain affects daily lives of women. And we've seen this in a survey that we did of 1,000 women that Healthy Women conducted the survey back in 2019. Can you go back to the previous slide, please? Women expressed that they had multiple chronic pain conditions and related comorbidities, some of which are shown on the word map, actually the slide before. And women also mentioned having a major depression, anxiety, and even PTSD. Now, looking at the impact of chronic pain in women, some of the key takeaways from our survey were that more than half the women expressed hopelessness and ability to live a full and active life. Almost half reported they're unable to sleep because pain interferes with their sleep, and there was a desire for patients to empower themselves with education. 1/3 reported they lacked access to enough information, and 56% said they need more resources. So communication seems key, especially between patient and providers, and there is a need for education for both. Next slide, please. In 2019, Healthy Women also held a 2-day summit uniquely focused on treatment and management of pain in women, where we also addressed barriers that women face when it comes to access to care. You can find the full report, video presentations, and relevant content using the link I've provided here. Next slide, please. So I just want to briefly discuss on the treatment and management of chronic pain and what we heard at our summit, as this was in line with what has been laid out by HHS Task Force report from 2018. So there is a need for individualized patient-centered care with a multidisciplinary approach using one or more treatment modalities, which I've listed in this diagram here on the right. Now, this care should incorporate the biopsychosocial model of care, which I'll just discuss in a minute. And there's also need for improving education for providers and patients, addressing existing barriers to care and need for continued medical research for new and effective therapeutic approaches to treat and manage pain. Next slide, please. So I want to spend a little bit of time on this biopsychosocial model of disease. This model was developed in the late 70s by George Engel and has been widely applied to pain. Importantly, this model highlights the interrelatedness of biological, psychosocial, and social factors, which are part of these 3 domains that you see here in the experience of pain. So when we apply this model to the challenges women encounter when accessing pain treatment and managing pain, it can explain how 2 middle-aged women with same age and chronic pain condition can report 2 very dissimilar pain experiences. So, for example, a woman with a strong family support and social interest may report mild pain and limited pain interference, and on the other hand, the woman with less social support and recent loss of spouse or having depression may report severe pain, substantial functional limitations, and depression. So basically, some of factors in one domain may influence the factors in others. Now, when we apply this model to see what barriers women face, we find that, for example, under the biological factor, we know that women have unique biological barriers and challenges, and they also have a differential response to opioids and non-pharmacological treatments. When you look at the psychological domain, you will see there are high rates of interpersonal trauma with PTSD, associated with high pain intensity and greater disability and greater emotional distress. Similarly, under the social domain, you will see that women are subjected to stigma from friends, family, and medical establishment. Next slide, please. So there are barriers that are actually unique to women of color. So minority women deal with not only gender bias, but also racial bias when it comes to having their pain assessed and treated compared to men. I've listed 3 types of barriers that are unique to women of color. So the first one is the physical barriers. And a study out of University of Michigan where they looked at pharmacies stocking opioids based on zip codes showed that pharmacies in white neighborhoods, even when low income, carried adequate supplies of opioids compared to minority high income neighborhoods where the supply was sufficient only half the time. So this represents an institutional barrier. The second barrier is the physician's attitude. So racial and ethnic stereotypes by physicians can affect the way pain is assessed and managed. Physicians have been known to discount pain in women, and this presumption is worse in minority women who report high levels of pain. As a result, women are often undertreated due to preconceived notions about their race and ethnicity. And we've heard this number of times. Doctors may undertreat minorities by not prescribing opioids because they see patients' pain as drug-seeking behavior. So this type of unconscious bias can actually erode communication and interaction between patients and providers. And finally, there are patient factors, such as patients' perceptions of pain can differ among racial and ethnic populations. Other factors that act as barriers and interfere with better treatment outcomes can include socioeconomic status, pain reporting, pain behavior, and mistrust of medicine. Next slide, please. So Dr. Mary Driscoll at our summit actually laid out certain factors that can help in addressing biopsychosocial barriers that I mentioned earlier to advance care for women living with pain. So for example, providers, when we come to providers, it's important for physicians to validate and address the burden of pain and improving communication with their patients, but it's also important for physicians to assume every person with pain may have a history of prior trauma and act accordingly. So that would inform, the practice trauma-informed care. So physicians should also sensitively address mental health and normalize the overlap between pain and mental health. Similarly, for patients, they should be able to identify factors that interfere with their pain and have a plan on where they want to be in the near future. So they should be able to communicate this to their providers, but also understand that their treatment and management may need interventions at the biological, psychological, and even at social levels. And this is making them basically be aware of the biopsychosocial model. Next slide, please. So how does COVID-19 and the current social unrest impact the treatment and management of pain? I mean, we have heard this, that there are limited healthcare visits now, and many interventional pain relieving procedures were deemed non-essential. As a result of this, women living with pain are missing out on crucial support systems at exactly the time when the pain may be flaring more than usual. So needless to say, all these factors have contributed to heightened anxiety and stress. And again, once again, you see from the survey from U.S. Pain Foundation, 77% respondents have said that they are facing barriers to medical care since the pandemic hit us. So next slide, please. Once again, I just want to bring your attention to the survey by U.S. Pain Foundation, where 1/3 of the patients living with chronic pain showed that they were concerned with contracting COVID-19, and also 1/3 wanted resources to help with handling added stress and anxiety. Now, I just want to point out that so there is a need for women. People are seeking more resources, especially women. And then I've just listed some sites here where there are resources that are available. But I think I also want to emphasize that we do need resources more specifically targeted to women, since they bear the burden of both chronic pain and mental health. Next slide, please. So at Healthy Women, we have been putting out a lot of content on our website targeted to midlife women, and I have listed some of the links here under these 3 sub-headings. You can also find more information on our website using the links provided, and also if you click on the main link, it will take you to more content. Next slide, please. And in the end, I just want to say thank you again for giving me this opportunity to share our work. If you have any questions, feel free to reach out to me. You can also follow Healthy Women on our on social media, and I have listed some of the handles here. Thank you.
Hi, Gretchen. You should be able to speak now.
Okay, thank you. And good afternoon to everyone. My name is Gretchen Wortman. Can we go to slide 32? Am I controlling the slides, or are you?
I'm controlling the slides for right now.
I am?
No, I am. I wasn't able to share them with you.
Okay. Oh, okay. My name is Gretchen Wortman. I'm Vice President for Policy and Program of the National Minority Quality Forum. The Forum is a 501c3 not-for-profit research and advocacy organization that was founded more than 20 years ago by Gary Puckrin in response to system inequities. The mission of the Forum is to reduce patient risk by assuring optimal care for all. And our vision is an American health services research delivery and financing system whose operating principle is to reduce patient risk for amenable morbidity and mortality while improving quality of life. Excuse me, next slide, please. We are nonpartisan, disease agnostic, and population-centric. Now, that does not mean that we don't engage at times on issues that are identified for us by partisan groups, or that we address through the lens of a particular therapeutic area. But as an organization, we are disease agnostic and population-centric. Next slide, please. We have a number of capabilities that can be brought to bear on any number of excuse me, policy issues, and that includes data collection and analysis, geomapping and publication of therapeutic area indices or indexes, policy analysis, education and advocacy, issue-specific alliance development and engagement, and community-based provider quality improvement initiatives. Next slide, please. In service of our mission and vision, we have identified a number of priorities that we consider to be essential components of a health services research delivery and financing system that is responsive to all population cohorts in our country that comprise this diverse general population. One is research designs that assure the statistically significant inclusion of population cohorts that are underrepresented in clinical trials and research. The second is the identification and elimination of clinical guidelines, formulary management tools, performance measures, and payment models that may serve to create, reinforce, or codify inequities in access to health services. Next slide, please. Next slide, please. There we go. There we go. Oh, wait. Okay. Diagnosis and treatment guidelines and prescription drug formularies that reflect safety and efficacy and provide clinicians with maximum flexibility in responding to patient needs and preferences. The next is the collection, analysis, and publication of data that identify and monitor diagnosis and treatment inequities in geographic areas and patient or beneficiary cohorts. Next slide, please. And perhaps most importantly, the fact that recent events have highlighted population-specific inequities and system-wide inadequacies in a manner that increases the potential to harness political and economic will to effectuate sustainable change. And I want to stop here for a moment because I want to speak to issues that were identified in the prior two presentations that speak to anxiety and stress and pain and mental health challenges in populations that are historically in the minority in the United States. And it's the fact that daily life for us for so long has been affected by the stress that we experience. And that includes a system, a health services delivery system that has a history of being non-responsive to us when we present, regardless of sex or gender. That I think there's an opportunity here that's been presented to us by the spotlight that has been shown on these system inadequacies as a result of the COVID-19 experience in this country. It gives us an opportunity here that we can't ignore. For many of us who have been aware of these issues for decades, the entire 40 years of my professional life, there has been an awareness of these issues. but I've never seen it on the front page before, the way it has been during the past 3 months. And that says to me that they, not only the political leadership, but the economically empowered leadership has acknowledged a need to recognize these system inadequacies. Now, they may be doing it for reasons that are different than the ones that we bring to the conversation, but regardless, the fact that that the issue was on the front page of the Washington Post, the New York Times, and articulated by the President of the United States makes this a very interesting point in our history with this system. Can we go to slide 40, please? 41. 41 is fine. The 41 is fine. Back 2, please. There we go. Okay. Regardless of the causes of the system biases that we've experienced over the years, we'd like to make some recommendations as we move forward that we are recommending that MHA and the stakeholders online with us consider as you make your decisions regarding engaging on this issue of reducing patient risk at the intersection of mental health treatment and pain management. The first is to put processes in place that define quality outside of the context of money. When money is on the line, then when money is factored into the prioritization process, the quality of care needs of patients tend to take second place or are engaged in service of constraining expenditures in the delivery system. The second is we encourage you to remember that populations are marginalized by external factors that human beings control. Being a minority in a particular country is a function of mathematics. It is not hardwired into one's DNA, and it may change depending upon your phenotype and the country in which you reside. So we need to take that into account when we use terms like minority in the United States. Next slide, please. We encourage everyone to seek and create partnerships and to be proactive in finding ways to collaborate in a pre-competitive or non-competitive space. And we say this because I'm going to say again, the issue of inequity in the health service delivery system has been documented and is an issue that has been documented for decades. But we have failed for any number of reasons to embrace it and bring about substantive change. One of the ways to do that is to find safe spaces for partners who have agency to bring about that change, and we encourage all of those who are participating in this call, including MHA, to find ways to create those partnerships. And again, we encourage you to recognize and constructively engage the political and economic levers of change. Failing to do that will cause change to be on the surface only, and it won't be sustainable. Next slide. We encourage you in your endeavors to evaluate all value constructs, performance measures, and quality measures through a patient risk reduction lens, both the development processes and their impact on patient outcomes. And we encourage you to find incentives to influence payer policy and provider behavior that don't put patients at risk for poor outcomes whether they are financial outcomes or health outcomes. Next slide. As part of this seeking of partnerships, we encourage you to work. We offer our services, our assistance, in helping you build an alliance of stakeholders in mental health and pain management to develop a strategic, evidence-based approach to improving outcomes. And we encourage that you collaborate with MHA and its stakeholders to produce a GeoMap index to support and monitor efforts to improve outcomes of care. Next slide, please. I do want to take a minute to highlight the data analysis and geomapping capacity that we have within the National Minority Quality Forum. These data analyses provide demographic intelligence about acute and chronic mental disorders at the zip code level, based upon administrative claims data for mental and physical health disorders and prescription drug data. I've lost you somewhere. There we go. We can map the prevalence, cost, outcomes, comorbidities, socioeconomic status, or other data types for any state, MSA, and congressional and state legislative districts. And these geomaps, again, these geomaps and analyses enable the monitoring of defined metrics to document patient experience and outcomes of care, to forecast trends using predictive analytics, and to produce customized reports to support policy advocacy and quality improvement initiatives at the federal, state, and local levels. Next slide, please. This is just a visual of a kind of geomap that we can produce that shows displays Medicare heart failure market in the United States. Next slide. You can, within the indexes, drill down to the state or city level. Next slide, please. And within the index, you can drill down to the zip code level for particular diagnoses, excuse me, or other variables. And we do protect for small cell size if that's a concern. Next slide, please. This is an example of the type of data that we can produce through for Medicare data that not only describes the patient or beneficiary experience, but the provider behavior based upon their claims data to Medicare. And so at the point at which your initiative may result in a community-based hospital or provider-specific quality improvement initiative, we can generate reports for you that help identify the target market for those initiatives and to monitor changes in behavior over time. Next slide, please. So what we would recommend you consider for this intersection of mental health and pain management is to look at mental health-related ICD and procedure codes, to look at the related physical health ICD and procedure codes, to link it to anonymized patient data that are available to us, prescription drug data that are available to us, and again, the specific physician-specific claims data. Next slide, please. We can also layer on top of that data associated with social determinants of health to the degree that they are available at the state level or a zip code level, if they have a zip code field assigned to them. I know that's hard to read, but the slides will be available to everyone after this presentation, and we can discuss them at greater length if you're interested. Next slide, please. And so I'm going to end with a quote, because I like to do that. I was an English lit major. In economics, things take longer to happen than you think they will, and then they happen faster than you thought they could. Next slide. Thank you. If you have any questions, please feel free to contact me at the National Minority Quality Forum. My email address is embedded in the presentation. And I'll turn it back to NHA. Thank you.
All right, this is Jessica Kennedy at Mental Health America trying from a different phone. Do I sound better?
You sound much better, Jess. Thanks.
Okay. My apologies to everyone at the beginning of the call when I sounded like a very loud robot. The upside from working from home is my dog is the cuddliest coworker. The downside of working from home is that my personal internet is just not as good as business internet. So it worked fine in the sound check. And again, I'm sorry to everyone's ears, but thank you all for filling in. I just wanted to take the time before we get to questions and answers to really thank Healthy Women and the National Minority Quality Forum for participating. Yeah, Healthy Women does critically important work around the impacts of health policy on women and families. And if you haven't gone to their website, it is just a beautiful website with great resources. You know, we work a lot in our policy folks run in the same circles with the National Minority Quality Forum. And they've just been an absolute leader in advancing health equity and quality measurement and really shined a light on the critical issues facing the existing systems. You know, CDC data came out today showing the huge disparity of how COVID-19 is impacting people by race and ethnicity, and it just again like strikes me how important the work that you do is. So thank you so much, Monica and Gretchen. I'm going to go to the questions now. So the first question we got from the audience, yeah, I will go ahead and link the website. So the first question we got was that SAMHSA has been working on integrated behavioral health and physical health for a while, and we've all been talking about it. So how have we made progress, especially in regards to mental health and pain, or do we just have a lot of work to do? We'll ask any of the panelists to address that.
This is Monica. I'll take a shot at that question. Yes, SAMHSA has done a lot of work in this space, and I think it is so important to, you know, elevate some of that work again. I feel like, you know, we are revisiting some of those conversations and some of the things that have been done, you know, 2024. But I think it's very critical to continue to build on the work that others have done, and that's how we can make progress. Can speak to, you know, have we done anything more since then from SAMHSA? But I think it's important to also note that the priorities change over time, policy issues change. But I think knowing that these resources are there, that information is there, we should be able to build on that.
Hi, this is Gretchen. I'll just add to that our concern stands that there is lack of representation from populations in the minority in the United States in the denominators of almost any science or research in this country. So I'm not, if SAMHSA has made progress, and I don't have specific knowledge of that, I would want to take a look at the populations, the inclusiveness of their data set to see if populations that are historically disenfranchised by science and research in this country are included in SAMHSA's work.
Great, wonderful, thank you. I also wanted to talk, as we're talking about treatment, someone said, can you discuss the reluctance or refusal to prescribe opioids for pain? I don't even ask for pain relief in the last few years. And kind of as a follow-up to that, what does the landscape of both opioid and non-opioid pain treatments look like?
Well, this is Gretchen. There's some interesting science or literature, I'll say, not science, some interesting literature about sort of that speaks to the difference between pain that's experienced by these populations that are in the minority, the degree to which they are, or we are, comfortable reporting that pain to a clinician for different reasons. And then the woeful inadequacy, far too often, of response from the health services delivery system. And what we've heard is that the system is, or providers, emergency departments, are loath to prescribe opioids because we are stereotyped as potential abusers of the opioids or dealers of the drugs, and are concerned about being accused of enabling that kind of behavior. And some of it comes from, I think, misunderstanding of certain data, and some of it comes from biases in the provider population. But I think the concern that's being addressed here is that opioids are often an appropriate therapeutic response to pain, and we need to more closely, more precisely examine the behavior of the health services delivery system and find ways to enable them to be more proactive on behalf of the patient with whom they are presented, rather than what may be stereotypical responses to stereotypical myths about certain populations.
And I just want to add to what Gretchen said. I've shared some information in my presentation. I don't know if there is a reluctance, and I think we've seen both sides. I mean, there are providers who are reluctant. There are also providers who are prescribing. But I think it's important to note one size does not fit all. I think you have to keep the patient at the center and then make a decision what treatment is right for them. And I think opioids work very well for some people, so we can't say that we're going to take them away or be reluctant to prescribe. But I think again, focusing back on what the patient really needs and what helps the patient is the key.
Those are great answers. You know, I know in my personal life, you know, I have people on both sides, right? So I have friends who are in terrible pain that have a very hard time getting pain medication that works from their providers. But I also have a brother who is a chronic heroin user, and you know, trying to get people to give him, when he asks for them, non-opioid pain for surgery has been a real battle for him, because he knows what a risk that is to his recovery. So I want to go back to the questions. What about pain in the LGBTQ population? So Maddy, I know we have a lot of screeners from that population. Do you have anything to add there?
Yeah, absolutely. So pain is definitely more often reported for LGBTQ individuals than non-LGBTQ individuals as well. So they often report higher levels of pain, but also higher degrees of disability from that pain. And we do also see from our screening data that LGBTQ individuals are more likely to screen positive or moderate to severe for a mental health condition as well. It's about 83% compared to that 74% in the general population, and that's even higher for LGBTQ youth. It's about 86%, and so I think that definitely connects back to what we all touched on in our presentations, is that tie-in with trauma and heightened anxiety and stress and discrimination. Definitely LGBTQ and other sexual minority and gender diverse populations face unique challenges and are more likely to experience trauma, especially in childhood, but throughout their lives, and discrimination, and especially are more likely to experience discrimination in receiving care and at a doctor's office. And so I think that's another really important place where we can stress more education in the provider community so that providers feel more comfortable and supported in discussing both chronic pain and mental health conditions and other healthcare issues with their LGBTQ patients. But it's also a really good place to acknowledge that we also need more investment and development of telehealth for LGBTQ patients so that they can receive more appropriate services from trained providers anywhere in the country, even where there may be a shortage of providers. But we also need to focus on creating more pathways for LGBTQ people to serve as professional and peer providers in both the overall health workforce, but also the mental health workforce.
Great, thank you. And I know we're at the top of the hour, but Monica, Gretchen, I just wanted to see if you had any final thoughts before we close this webinar.
Nothing other than to thank you for this opportunity to present to this audience. And I would reinforce the statement about telehealth, not just for the LGBTQ plus population, but I think one of the learnings also from the past few months is that there are opportunities to use technology that's been available to us for decades in ways that are much more supportive of our general population than we have used in the past. We need to look at telehealth as possibly a first line of access for all populations, not just LGBTQ. Thank you.
And I just want to add, this is Monica, that, we've focused on these presentations today about minority health and also just specifically women, and we've not addressed much of LGBTQ issues, but I think it's so important to include that group as well and really try and understand the issues that they face coming to chronic pain and as well as mental health. Perhaps that's a topic that Mental Health America can address in the near future. And once again, thank you. Thank you for including healthy women.
All right, well, I just wanted to thank you, Monica, Gretchen, Maddy, so much for participating. This was such a critically important topic. This was a very informative webinar. I loved being on it. The attendees have thanked you, want the slides, want certificates. So for those of you looking for certificates, we'll keep it open just a little bit later to type the email in that you should send that to, but otherwise this is the conclusion of the webinar. Thank you for joining us. Recording will be available on our website shortly. Thank you again, everybody, and have a great week.
Thank you.
Thank you.
Thank you.